So I wanted to thank everybody for lots of things. So Dr. Klinga asked me to speak about a year ago, and actually this was the title of the talk that she gave me. So this is what she asked me specifically to speak about, and I wanted to thank all the previous speakers before me, because as we've already discovered, there's been so much overlap in all of these conditions that pretty much you've all done my job for me, and you've all talked about everything I'm about to cover. So hopefully we'll be able to keep this short and very dictated towards exactly what my role in this process is. So just as a disclosure, I don't have any actual disclosures, but I do sit on the board of directors for both the Dysautonomia Support Network and the Coalition Against Pediatric Pain, both which have vendor booths out in the waiting area. So, and there are pictures of patients in the presentation. We have disclosures for all of those, and there's no HIPAA violations. So these are the objectives that you guys can read that I submitted for your learning purposes, and we will hopefully cover all of them in detail in relationship to my scope as a physical therapist and how it relates to all of these conditions from my perspective. But if nothing else, this is the only slide that I care about. If you learn nothing else from me in this entire presentation, please don't forget this. So my goal is that by the end of this presentation, hopefully you will have changed what physical therapy can do for this patient population. You will change your perception of physical therapy in general, because PT is not just exercise. PT does not stand for physical torture. I'm sorry. And PT extends far beyond just muscles and joints, and because as PTs, we are licensed to treat connective tissue. That is literally what we do. We are motion experts, we are biomechanics experts, and we treat connective tissue. That's our job. So what do PTs do then if we're not exercise people and we're not torturers? So physical therapists, we treat somatic dysfunctions, which means we treat dysfunctions in the body. So a lot of the words, I'm going to be covering pretty much exactly what everybody else has already talked about, but using my language and my scope and my perspective to look at it. So physical therapy, we treat the altered or impaired function, structure of the related components of the somatic system. So the somatic system is anything within your body. More specifically, we deal with the myofascial and skeletal structures and the related vascular, lymphatic, and neural elements. If you look up the definition of what physical therapy is, this is what we do. This is what physical therapy is. Underlining the fact that we deal with, again, I'm not a doctor. I'm not a medical doctor. I do not treat the brain. I do not treat a nerve. The surgeon will do that. But I treat patients that have deficits in these areas. So I treat the connective tissue around these areas, and that's how we all end up working together. So Dr. Klinga asked me, we had a long talk about what she wanted me to talk about, and she really wanted me to speak specifically on my unique perspective and what makes kind of me different than what you think of when you think of PT. So I was trained with a very different kind of high-level osteopathic manual therapy approach to PT. I spent a lot of time doing osteopathic training after I finished grad school, and so I wanted this to be a very targeted discussion on the neurological deficits related to connective tissue disorders from a PT perspective, specifically from a manual therapy-based perspective, but taking the neurological route. And so a lot of the generalized PT stuff that I took out of the lecture, I coordinated with Kevin beforehand, so we don't have any overlap. So the second lecture, hopefully I'm going to leave some extra stuff I'm going to skip some stuff of mine to let him have more time. So we've already talked about this, but connective tissue disorders. Connective tissues are made from collagen. They're made from the building blocks of collagen. Collagen is the support structure that provides strength to all human tissues, and it's the glue that holds us together. And then, so when the building blocks of tissue are defective, it can lead to systemic weakness and instability. So when the glue that holds your entire body together isn't strong enough, that makes your whole body not strong enough at a systemic level, not just at a joint level or a specific muscle. That's very localized. We're talking with these patients at a very kind of systemic susceptibility. So I don't want to overwhelm you with this slide, but basically you can read it yourselves. Signs and symptoms of connective tissue disorders from a neurological perspective. I have seen in my clinic pretty much on a daily basis that patients come in with 1, 5, or all of these. And if you look at the common signs and symptoms of these, every single one of them, the core link of what the underlying root for all of them is to me it looks like a nervous system issue. Every one of these issues can be related back to the nervous system at some level. We're going to talk about some of them in particular. everybody did a wonderful job. Proprioception, we're going to talk about that. Proprioception is one of the things that we tend to overlook in all of our patients, but it's one of the main factors for patients with connective tissue issues that is even stronger than our standard population. But if you look at most people that go through, PT for even the nurse's typical population, normal athletic injury, it's the one area that nobody really spends enough time on. It's what you get to at the end of therapy, and you're done with therapy. You don't really want to be there anymore, so you either stop early or you want to get back to life. So they forget that part, or you skip it yourself. So when I tell patients or I tell students that I'm teaching, they're like, well, what do you do? What is EDS? What is this? So I use this analogy where if you look at a house, this is what your typical house looks like. Very cute. Then you look at a house that had EDS. To me, I don't know, they look exactly the same. So from the outside, they look identical. There's nothing different about these patients, which is what we've already talked about, which is the problem. But when you look closer, the typical house is built out of nice, strong 2x4s that are solid in structure, and there's a lot of them. And when you look at your house that's built from EDS, you have less 2x4s, and the ones that you do have are all riddled with termite damage. They're already structurally deficient. So when you build that house, it doesn't matter how long it's going to take, eventually they're going to look like this. And if they don't take care of themselves, this is what's going to happen, and this is how they walk into my clinic. So for this is what your patient with EDS feels like, even though they may look like something like that first house, they feel like this, or they eventually will look like this if you can't help them early enough. So for this talk, and specifically, I want you to picture your house itself, and picture all of the electrical systems in your house that run through the walls and the wiring and the lighting. And once this happens to your house, what's going to happen to the lights in the upstairs windows? They're probably not going to work, because I'm pretty sure that the nerves have been busted through those walls. So now all those electrical wires have been frayed and pulled on, and that's probably not making your patients very happy, which is pretty much every lecture we've already had up until this point. So the difference between allopathic and osteopathic approaches in physical therapy, at least. So for me, I was trained very much from an osteopathic standpoint. All standard PT schools are more of an allopathic. It's a bit of both, and I think you need both in order to have a complete program. So osteopathic is more of a structural rehabilitation approach versus allopathic, which is a functional rehabilitation approach. So with structural rehabilitation, you look for a recovery model. You look for a host-based model of my patient with a connective tissue disorder or my patient with a problem. And then you treat the root cause of that problem from a structural manual perspective. Functional rehab is your patient has a problem, and then it's a compensation-based model. So if your patient is limping, you don't correct the leg length discrepancy or the pelvic obliquity that's causing the limp. You give them a cane so that they don't limp. So that's kind of on a very gross scale what the difference is. So with structural manual therapy, we do a lot of different types of techniques. So they're all listed here: muscle energy, myofascial release, strain, counter strain, cranial therapy, cranial sacral therapy, visceral mobilization and manipulation. When patients or other therapists that I talk to, they're like, oh, are you a cranial sacral therapist? I'm like, no, I'm a manual therapist. Cranial sacral therapy is maybe 1/10 of what I do, because it's one of the tools that I have in my toolbox. But you have to use all of them in order to treat your patients effectively. If you don't know all of these, then you're not an effective therapist. So you cannot be a muscle energy therapist. You cannot be a stretcher. You cannot be a joint mobilizer. You have to know everything. You can't just be one thing. And that's unfortunately what people tend to do, is they get really good at one type of technique. But you can't help your patients, especially with connective tissues, if you don't know how to treat everything, because they're not going to come in with just a knee replacement. So you can get really good at being the knee guy. You have to treat everything. And that's very overwhelming for PTs and practitioners in general, because once you go through the rabbit hole of treating this patient population, you realize that you can't ever go back. And once there's one thing wrong, then they come in with everything wrong. And then once you help them, then everybody else keeps coming too. So you really do have to do a comprehensive approach for everything. Functional therapy, those are your techniques, all extremely valid and necessary, and you have to be able to incorporate both sets in order to be a good comprehensive therapist. So the ones that most people think of when they think of PT, which none of you are ever going to do again because that was the only slide I asked you to remember, is PTs only do posture education. We do stability strengthening exercises, and sometimes we do gait stuff. Those are 3 of the multitude of things that are listed here. and none of you are ever going to remember that, because that's the only thing you have to remember from this talk, is that we do more than just that, I promise. So from my perspective and the way that I was trained, we really deal with the structure-function relationship. So in osteopathy, at least from a PT perspective, the phrase is that structure governs function and function influences structure. So if you think about it from a very local example, if I have a tear of my bicep muscle and it hurts and it hurts and it's injured, it's structurally deficient. Therefore, I can't lift something up. That's where my structure is influencing the fact that I can no longer pick something up because it hurts or it's weak. Whereas if I have a job where I pick up heavy things all day long, this is my function every day. Well, that function every day is eventually going to lead to probably some sort of like tendonitis in my elbow, and structurally or functionally and structurally, this bicep is going to get stronger than this one because I spend all day lifting something with this arm and nothing with this side. So there has to be that dichotomy relationship of one and the other in order for this to work. You can't just be one. So you can't just be a structural therapist and say, I'm only going to do the manual work because that's the stuff I like. Because if you do that and you don't ever follow it up with the stability strengthening and proprioceptive training, you're giving your patient half a treatment. And that makes you a 50%. And to me, that's an F. And I don't know, I didn't like ever wanting to give an F to a student, but I definitely never wanted to ever have one. So this is the PT perspective of the last two lectures, which were done in much higher enthusiasm, and the histological perspective, everything that was spoken about 2 lectures ago is this. She spoke about it from a histological standpoint, and so this is us. So this is that example of bicep tear. So my red over here, this is my bicep muscle and the cross-section of my spinal cord. So if I normally have your afferent info going to the spinal cord, tells your muscle to contract, sends out the efferent info, your muscle contracts, and that sends that info back into the spinal cord saying, okay, this is how this loop works. It's, normal. Well, if there's an injury there, now it sends more afferent info in saying, that kind of hurts, something's wrong, I'm in pain. So your spinal cord or your nervous system says, well, if there's an injury, do something about it. If there's a tear, you should make it shorter so you don't get injured further. But now you've just shortened an area that was already injured. Now you've pinched on the nerves and you pinched on all that amazing glutamate, all that stuff. You've now made that worse. And so your body says, well, that hurt more. And so it sends that loop back in and it creates this cycle that won't go away. And it's what we call a facilitated segment. That's the way that we term things. So this facilitated segment is setting you up for failure. And it's not going to change until you change something. But what happens is eventually, if you're not listening to that, nobody really, it's your bicep muscle. It's not that important in your overall life and your overall health. So you can ignore it really well. You can ignore the fact that it hurts and you can go about your business. So if it's really an injury, your body's going to say, all right, well, you know what? You weren't listening to me and I told you that I was in pain. So you weren't listening to your arms. I'm going to start sending this information somewhere else. So we talked about, in other lectures about having autonomic systems. So all of your nerves, all the different spinal segments have your afferent, your efferent, and then there is also an autonomic nervous system component that goes out of every spinal nerve. So if you're not going to pay attention to the motor nerve that I'm trying to send out this signal to, I'm going to send it to somewhere that maybe you will. So maybe you won't deal with your shoulder pain that you're having, but I'm going to start to send it to your heart. And now you're starting to have heart symptoms. And maybe you'll listen to the fact that you're having chest pain and heart palpitations. And do you have a heart problem? Maybe not. You might. That's a different condition. But your body is trying to give you well, you didn't pay attention to the little thing, so now I'm going to send this info to a bigger thing. And now you set up this cycle where the heart says, okay, that doesn't feel good. Now that's sending signals back. So until you start to deal with, well, what was the cause, and breaking that cycle, you can't break that facilitated segment. And that's what we deal with. We treat facilitated segments in PT. So when you treat that level, you're treating the root cause of what's causing the cascade that's now going off in your body, in your patient's body. So specific to the cranial cervical junction, we have, again, everybody did a nice job of setting this up for me. We already had a great lecture on all of this. So you have your skeletal structure of your cranial cervical junction, what we call the OA junction, and then you have all of your myofascial tissue. You have your neural elements, your muscles, your fascial elements. That's all well and good. And we treat patients in physical therapy all the time with neck pain, headaches, especially with my population. I get patients from Dr. Klinga all the time, specifically because they have a Chiari and they have all of the symptoms that we've already talked about and cranial cervical instability. So we treat these patients all the time. And prior to this lecture, you thought this is all we ever thought about, but I want everybody to remember that the cranial cervical junction, underneath all of this skeletal structure and myofascial structure, we have to respect the fact that there's a brain tissue under there, and there's more than just, so as I treat something, I have to respect the fact that there's more important structures underneath. So it's not just a muscle getting impinged. And if my patient comes in and their head isn't aligned properly on their spine, whether it's from a muscle spasm, it's not just the spasm that I'm worried about. It's, are they now causing neural compression because of their postural alignment? And that's very important for me. So, anatomy, the biomechanics of the OA joint. You have convex condyles on concave facets causing what we call a type 1 motion. So it's a side bending and rotation in opposite directions. So if you were to move your head, side bend and rotate in opposite directions, that's one of the key markers that tells me that it's your OA joint versus the lower cervical joints, which have a different type of motion. So that's how you can identify the difference between the two. When I look at somebody from a clinical perspective, I'm not looking at their arthromechanics on an MRI, I'm not looking at their specific numbers, I'm looking only at their functional outcome. So when we look at the biomechanics, the central picture in the middle is the neutral, and then we have your side bent left and rotated right, and we have your rotated right and side bent left. So the one thing on the bottom there is the brain attempts to keep the eyes level with the horizon line. So if I have a patient that comes in and they're in one of those pictures that it's on the side, to me that tells me that they're already in, they're in more of an acute pattern because their brain hasn't had time to accommodate to the fact that they know that their head is crooked, and you don't walk around all day with your head being crooked. Your brain eventually is going to tell you that you need to straighten it out, and then other things are going to happen. But if I lie them on the table and I look at them and they're neutral and standing, and then I take away that visual horizon line, and then they present with that pattern, I know that there's a neurological underlying condition that's causing that to be prevalent for them. We already talked about Chiari, so that position of the head and being able to treat that effectively and bring them back to a neutral mechanic will help decrease the strain on the connective tissue and the brain tissue underneath those biomechanics of the skull. Dealing with the way that we treat things, we have different ways of describing things, but we deal with the reciprocal tension membrane and the dural system, and the connection between the Chiari brain symptoms and the tethered cord symptoms. They're very well connected for us because the dural system connects the two ends, and we end up treating both because they're structurally linked. You can't do one without the other. Dysautonomia is, like we already talked about, blanket term for the malfunction of the autonomic nervous system, and when things go haywire there, it affects the entire system. And since, hey, PTs now treat connective tissue, which treats the entire system of everything, somehow everything we do is going to have an effect on the whole body. So just a clinical correlation for that. Dr. Chopra already mentioned that ribs sublux, big deal for us. Most people don't think that ribs move, they do. So if you look at the rib at the costovertebral junction, the rib is very closely linked. It's surrounded by all these ligaments, but the sympathetic ganglion of the autonomic nervous system lie right in front of it. So if the rib subluxes or the rib moves, and then that pinches on that nerve, that's going to prime the patient to set them up for a dysautonomic reaction. So they might be having these other symptoms, and they don't recognize their rib pain as the issue. They recognize all the other symptoms. So being cognizant of the fact that you know your anatomy and that this patient may be having a rib issue because they're complaining of all these like weird POTS flare symptoms, or their heart or their GI system. If your rib at T6 starts to sublux and that's the rib that's the issue, you're going to have stomach issues, not because you have a stomach problem, but because the autonomic level of T6 is the level for your stomach. So if I can help you with my practice reduce the subluxation of the sixth rib, that's going to take away that dysfunction, which is then going to maybe take away some of your other symptoms, and maybe you didn't need those medicinal treatments for your dysautonomia that day. Maybe I can help, decrease some of that with a structural issue. So again, we already talked about why that works, but that's why your stomach would hurt if you had a rib subluxation. Then the only other thing I wanted to add was the proprioception. Kevin's going to talk about all the other types of treatments. So with the proprioception, I really harp on this for a lot of my patients. So I treat the proprioception early on, doing different types of activities. And the reason I picked some of these pictures in particular is these pictures show what should be, in most people's minds, really high-level agility athletic activities. So you don't normally do these until the end of therapy. So this patient was actually working on her proprioception because she has no concept whatsoever of where her body is in space. Like Dr. Chopra said, every one of my patients has this. But the ironic thing I wanted to point out was that these pictures over here look like they're higher level functions. She was actually in a much medically higher level state at this point than she is in this one. This was actually her first day her first day of being able to stand weight bearing after having 2 surgeries, a spine surgery and a knee surgery back to back. And this was actually, she's actually at a stronger physical state in this picture here than she was in these over a year and a half ago. Because of subsequent injuries that occurred, but this is her learning how to walk again from a proprioceptive perspective. She had the strength to do it, but she wasn't allowed to use those legs. So we can skip the questions, and thank you.